My name's Eden. I'm the Associate Director of Programs with PMD Alliance. And with me is my fearless sidekick and online programs manager, Kelly Merkel, who's in charge of all the tech, which is good because nobody wants me to be in charge of tech. So your chats are open. Closed captioning will be turned on. Also, if you want to save your chat, there's going to be 3 dots. And if you click on those, you can save the chat if you're just, wanting to see what people's questions were and stuff. We are very excited to have Maria Allen and Sidney Collin with us today. They're going to be speaking kind of back to back, so I'm going to go ahead and introduce them both. You can put questions in the chat, but we are going to save them for the end. Maria has over 37 years of experience as a physical therapist, treating people with brain injury, stroke, neurodegenerative disease, and vestibular dysfunction. She began to focus on the Parkinson's population, first by becoming certified with LSVT Big in 2011, and then Power Moves, certified in 2013 and 2014. She's been developing and serving as a coordinator of a multidisciplinary Parkinson's wellness program, and we're so grateful that she's here today. She's also working closely with her community, serving as the board advisor for the Central Coast Parkinson's Association, as well as a volunteer advisor for NexStride. We also have Sidney Collin, who's the inventor of NexStride and the co-founder and CEO of Deoro Devices. Their mission is to develop products to improve mobility, independence, and quality of life. NexStride does just that as a small portable device that uses research-backed sensory cues to help people with Parkinson's overcoming freezing of gait and walk smoothly. We're so grateful you ladies are here today.
We're so excited to be here. Thank you for that introduction, Eden.
Thank you very much. I always love to talk.
So I'll go ahead and share my screen, and Maria is going to kick us off, and then I'll jump in at the end here.
All right, okay. So I've got it up there, the wonders of technology. I'm so happy to come to, I'm gonna put myself, let's see if I can see myself as well. Okay, good. So today's topic is falls and freezing of gait and Parkinson's disease. We want to talk about what it is, some of the reasons why it happens, and give you some ideas on prevention and tips for preventing those falls. And it's really quite a timely talk today. Let's see if I can get this to work. No, go ahead and advance it for me, Sidney. It's not going now. It's actually Falls Prevention Awareness Day is this month on September 22nd, and there's a whole Falls Prevention Awareness Week, which is September 18th through the 24th. And it's a very important topic for our elderly, which I'm actually almost in that elderly population now. At my age, I fit into some of these statistics. So we talk about how often people fall and how falls are such a cause of serious injury. 1 out of 4 older people fall, 1 out of 5 falls causes a serious injury. Falls are the leading cause of emergency room visits, the 2nd leading cause of accidental death worldwide. And every second of every day, 1 adult over 65 years old falls. So we think about that even in the general population who's not dealing with any kind of neurodegenerative disease is falling on a fairly frequent basis, and it's creating injurious falls. They're expensive. There's a lot of issues there. But people with Parkinson's actually, that we think about 70% of people with Parkinson's fall on each year, and that a large proportion of them fall recurrently, so more than once a year, more frequently. We know that even those newly diagnosed, even early on in Parkinson's disease, you can have more issues with falls and falling. There we go. Okay, I think I went too far now. Can you go back for me, Sidney? 1, 2. 3. So some of those risk factors for people with Parkinson's disease, why do they tend to fall more frequently? Some of the risk factors include, if you've been living with Parkinson's disease, the longer you live with Parkinson's disease and the greater the severity of your Parkinson's symptoms, the more risk you have for falling. So especially if you've had Parkinson's disease more than 10 years. And we know that Parkinson's disease, you can live with Parkinson's disease for many, many years, for 10, 20, even 30 years. We know that the longer you live with Parkinson's disease, the more those motor symptoms impact how you're able to move and some of those things you're able to do in your daily life. So we know the longer you have it or the more severe your symptoms, the higher your risk of falling. We also know that freezing of gait is a risk factor for falling. And that's what we're specifically going to talk about today is issues that deal with freezing of gait. Having issues with cognition, so having problems with your thinking and your memory and all of those things are risk factors for falls. Balance, posture reactions, all those automatic, being able to catch yourself when you start to lose your balance. We call it in therapy, we talk about postural instability. All of those things are risk factors. The fact that you're moving slower, that's that Parkinson's disease symptom of bradykinesia, where your bigger movements tend to be slow. It's harder to get moving, your gait speed, so how fast you walk is usually slowed down. You tend to either take lots of fast little steps or you're taking bigger, slower steps, but that slower gait speed is a risk factor. As we get older, we do tend to get less active and have more issues with weakness, especially in our pushing muscles, our extensor muscles. So lower extremity weakness is a risk factor. And then in Parkinson's disease, although it's very heterogeneous, which means everybody with Parkinson's has a different kind of set of symptoms and problems, they've identified a couple of typical subtypes, motor subtypes. And one of them is called postural instability gait dominant. The other is called tremor dominant. So people who have posture instability gait dominant subtype, they tend to be stiffer, have more problems with being stiffer and slower, and tends to be the people who are diagnosed a little later in life. And they're the ones that tend to have more of a fall risk problem. So thinking about how all that stiffness and rigidity creates some of those risk factors for falling. Good, I just have to be patient when I push the button. Thanks, Sidney. This is a little bit of a busy chart, and it's from the Movement Disorder Society and an article talking about what happens when you start having frequent falls. So things that are going to contribute to frequent falls in Parkinson's disease, again, those balance problems, things like freezing of gait. Your environment can obviously create risk for falls and create falls, but all of those things that are feeding into these frequent falls, and those frequent falls then lead to an increased rate of fractures. So I think there's like 4 times more hip fractures when people with Parkinson's fall. So you're at a higher risk of fractures all over your body, but hip fractures particularly. Other injuries, there's lots of skin tears, other types of injuries that occur with frequent falls. And I think one of the most debilitating things is every time you fall, that feeds into this fear of falling. And we know that if you are fearful of falling, you're actually at an increased rate of falling. So that balance confidence, having confidence in your balance is very important. So these frequent falls are going to affect all of these different things, and you're going to become less mobile. So when you have a fracture, you've got other issues, or you're just afraid to move, you become less active. And we know that people with Parkinson's, the less they move, the less active they are, the faster those symptoms tend to progress. So moving, and as a physical therapist, I'm moving and exercising is key to living a good life with Parkinson's. All of the other things that happen with not moving include, you get weaker. You don't have a good cardiovascular fitness level. You can't tolerate a lot. You get more constipated. You have more problems with weaker bones, problems with sleeping, and you're more socially isolated. And all of those things lead to a faster disease progression. Your brain does not work as well when it doesn't have exercise, when it doesn't have socialization. All of those things are leading to this reduced quality of life and bad things. So we know we have to keep people moving. We have to keep you moving safely, and we have to try to prevent and reduce that risk of falling. So let's talk about one of those ways we can do that for people with Parkinson's. We can talk about what freezing of gait is, how we talk about it, some of the language that goes with it, and how it affects falls, and then things you can do to help. And I am a physical therapist, so I'm going to talk a lot about how therapists treat fall prevention and freezing of gait. So freezing literally is just that temporary, involuntarily inability to move. People will say, I feel like my feet are stuck in cement, my feet are glued to the floor. It is just this interruption in the ability to keep moving. But it isn't only in gait. It isn't only in walking or in your legs or your feet. Freezing happens across all your different motor symptoms. You can have freezing with your upper limbs. You can have freezing in your speech. There can be issues with freezing with swallow and thinking. So it is a symptom in Parkinson's, a problem in Parkinson's, but it affects all different symptom systems. But we're going to talk about freezing of gait and how that affects your fall risk. So it is very common and disabling in people with Parkinson's disease. Some research, one paper may say it's 15 to 70%, another paper may say it's 40%. It's hard to know exactly how many people with Parkinson's disease experience freezing, but it is a common symptom and it is very disabling. It leads to a lot of that social isolation and inability to get out and participate in life, which then is very disabling and impairs your quality of life. So those sudden and brief episodes of inability to take that next step, to pick up your foot and move, it happens a lot when you just get started. So say you get up out of your chair, you can't get that first step. You can't initiate that first step. Sometimes you're walking along and it happens when you go to turn. It very frequently happens when you're going through a doorway, narrow spaces, changes of surface. If you're going from carpet to tile or indoors to outdoors, it happens a lot under stressful situations. So in crowds, outside, especially when there's a time pressure. And it's an element of it is this idea of dual tasking. So we'll talk a little bit about what that means, but we know that it affects people with Parkinson's disease and their quality of life quite severely. So some people, when they this freezing, they may have kind of this, their legs just kind of tremble. They're alternating, they won't go, and you just can't pick one up and take a step. You just can't get going. And it's very exhausting and very scary to have that happen as kind of that leg movement. Some people they get into that small shuffling steps and they get smaller and smaller and they just can't get out of that small shuffling steps. And some people they get stuck. We call it akinesia. They just cannot move at all. We talk about freezing sometimes based on what we think is the trigger or the cause. Some people have anxiety triggered freezing of gait, where when they're in an anxious situation, their brain is just going a mile a minute and it can't calm down and focus and can't take those good big steps. There's a lot of issues with cognition. When we think about how Parkinson's affects our ability to do more than one thing at a time, and we call it set switching or pay attention or keep paying attention or prioritize what we pay attention to. There's a lot of issues there with attentional impairments. And then sometimes we're looking at, well, is it really this forward flex posture, this narrow base of support, and this slow reaction time, slowness of your movements that's creating some of that. So there's lots of things that can cause that freezing of gait. It's not very well understood. It's very complex. It all relates to this issues in your basal ganglia in your brain, where you don't have enough nerve cells producing dopamine. That chemical dopamine is what helps regulate your body's movement, and it helps regulate your ability to perceive how you're moving and how you're talking. So think about that, your perception. Some people with Parkinson's have that small handwriting or small voice, and you're moving slower, but you don't really realize that you're moving because dopamine and your basal ganglia help regulate your body's movement and your sense of how you're moving. By the time you're usually diagnosed, you've already lost 50 or 60% of those cells that are producing dopamine. So you don't have as much dopamine in, we all lose dopamine as we get older at like a rate of 4% a decade. So as we get older, our brain doesn't produce as much dopamine, but when you have Parkinson's, it's starting to happen at a rate of 25% or 30%, it's starting to happen at a real rapid progression. And they're doing lots of research, and hopefully they'll come up with some things. And, there's a lot of good research going on, but thinking about that lack of enough of that chemical in your brain, that dopamine, is where things happen. So your dopamine, we'll talk about some of the different ways dopamine is used by your brain to help with motivation and reward, just kind of emotional things. It's a lot to do as a signal. It's how your brain cells communicate with each other. So we want to work on that. How do we improve that? So we know that we can work, as a therapist, I want to work on, tapping into all of those different loops of basal ganglia, where your pathways address those automatic everyday movements. So that's what we think of when we think of Parkinson's. It's like all of a sudden, not all of a sudden, but over time, you start losing the ability to do those easy things that you've done all your life, like roll over, get up out of the chair, do those simple tasks that we've always done. That's your automatic or your habitual, and it affects your daily life, like getting dressed, taking a shower. All of those things are affected by that loss of that automatic or habitual movement. We also can use more goal-directed movement. So thinking about that in terms of, if I go to do a task, so I can reach out and I say, just, straighten your arm, or I can say, hit this, touch this. So if I give you a job or a task, your brain's going to react differently than if it's just trying to do something on automatic pilot. One of my favorite examples of this is thinking about driving, right? Most people start driving when they're 15 and a half, 16. Sometimes if you're on the farm, you start driving even younger, right? By the time, so I've been driving for 45 or more years, right? So that's a very automatic process. I don't think a lot about what I'm doing when I'm driving. But last time I drove in England, right? I'm driving on the wrong side of the road, the left side of the road. And it's a new task. And I have to rely really heavily on things like these little white arrows on the blue sign that tell me which side of the road to turn onto and which side of the road to drive on. So that I'm using an external cue. I'm using something externally to help me figure out how to do this job, to drive safely in England. And over time, if I drove over time in England, I would learn. That would become then more automatic over time. And that's what we hope we can help people with Parkinson's do, is become, drive that brain to use things and get things to be more automatic. But sometimes there isn't enough dopamine, there's just not enough. And so those external cues need to stay, or those external devices or cues can help you. So we can tap into those goal-directed or task-oriented things to help drive better movement. We want to work on that ability to pay attention and to focus and stay attentive to what you're doing. So there's things about using external cueing and things to help keep that attention. Most falls, and what I see with people with Parkinson's, a lot of falls happen when people are not paying attention, right? So if they're focused, they're distracted, they're not really paying attention to the task at hand. So that's a lot of times when those falls happen. And then those basic things, we can tap into things that are motivating, the things that are emotionally that are important to you, and make sure that we're getting you out, moving, doing the things that you love to do, spending time with your family, getting out, and those social connections are really important. So we know that socialization actually makes your brain heavier. It weighs more if you have a lot of good social interaction, and you get more, your neurons connect better when you have a lot of socialization. So we've all been through the pandemic. We're all still a little bit on that, fearful and isolated side, but we're at least here all together. There's a lot of us all together on Zoom talking about this, and we want to make sure that we try to maintain your ability to move without that risk of falling or with less fear of falling, and stay connected with your peers, right? Get out and do things. So ways that the treatment options, what do we do for freezing? Number one, you want to talk to your neurologist, your movement disorder. Hopefully you're able to see a movement disorder neurologist, if not your general neurologist, but talk to them about your medications. Typically, we know that when you take a medication for Parkinson's, it's the first line is that dopamine replacement. So putting more of that missing dopamine into your brain so your brain can function better. There are other medications that help, that are agonists or inhibitors that do other things to help your brain use your dopamine or work more efficiently. But if your medications are not optimized, then you're going to get into those off times when you're stiff and you're slow and you just can't get going because you don't have enough of that dopamine. It doesn't stay in your system a long time. Usually it's in and it's out unless you have a Duopa pump or you've got the long acting. There's lots of things to talk to your doctor about. But freezing often happens when your medications have worn off or are wearing off or haven't quite yet kicked in. So looking at your timing, your schedule, all of those are things to take good, keep a diary, take a note, see when your freezing happens, and make sure you talk to your physician about that. If you haven't seen a therapist, then I recommend you see a therapist. There are physical therapists, occupational therapists, speech therapists who can all help with some of those problems that are causing the freezing and the falling. I recommend you see a therapist that understands all of those Parkinson's disease symptoms and understands how to work with you. There are things you can use that are external cueing strategies and devices, and we'll talk more about those. And then there's internal cueing strategies and devices. Working on your executive function, working on how well your brain can focus and pay attention and do more than one thing at a time. There's lots of ways to work on that. And I recommend highly you see a speech therapist for a baseline cognitive assessment early on, so you know if you have areas and places you can work. And DBS has some efficacy. They're not quite sure, but DBS is deep brain stimulation. It is neurosurgery. It acts like medication. So of course, if medication helps with freezing, then DBS should help with freezing as well. But it's a little, it's a bigger process than just taking a little bit of medication. So talk to the doctor about all of those. They use the levodopa, carbidopa, levodopa. There's lots of different forms of that. There's things like rasagiline, selagiline, and amantadine that have some research that shows those help. I've seen there's really kind of controversy over whether giving you something that helps you pay attention, which is what MPH and Ritalin are. They're for helping your brain stay focused. It's a little bit less, sometimes they try that. So if your doctor wants you to try that, that's what that's for. It's to help your brain stay focused and pay attention to reduce your chance of freezing. So, but it's a little controversial as to how well it actually works. When I think as a physical therapist, first off, if I can address the underlying problems that you have and get you better, restore your functional mobility, that's what I want to do. If I need to, I'm going to compensate and use some tools to offset that problem. So I'm going to teach some strategies. And then sometimes we have to adapt. We have to look at the environment. We might have to, enhance your environment or add some assistive devices, add some different things, or there's ways to adapt so that you can continue to live a good quality of life and enjoy your life despite your freezing. So when I think of restoring or addressing these underlying problems, I think about, everybody with Parkinson's, we know there's this tendency to get into that flex posture. Your extensors get weak, get stiff and rigid. Those flexors kind of pull you into that flex posture, and that leads to a lot of balance impairment. So we want to work on that posture and getting you up tall. We want to work on that bradykinesia, that movement problem where your movements are not the right size and speed for the task at hand. We want to work on that rigidity and that stiffness. That's a lot of cause of problems, a lot of cause of pain. You lose a lot of that fluid movement when you get so stiff. So therapists can help you a lot. We can help you a lot with some of those cognitive problems with how your movement is coordinated, the timing and the sequencing of it. So a lot of people think that they're getting weak when they have trouble getting out of a chair, but it's really their Parkinson's symptoms that are causing that. They're not putting in the right amount of effort, amplitude, and velocity. That's not enough oomph, or their coordination of their movement is off. So they don't lean forward before they start to push, and they end up just going back in the chair. And then they just get stuck in those fast, small movements and need to stop and get out of them. So we can work on, lots of those issues of how to help you move, working on practicing, changing when the rules change, when the surface changes, when you got to look somewhere else. How do you deal with all of those things? And we want you to be exercising because your brain needs exercise to be healthy. You need to get that brain lots of good exercise. And there's lots of research on that. Managing your anxiety, OTs are especially good with this. PTs can help you with this as well, but mindfulness, thinking about how do I calm some of that anxiety? How do I deal with some of this stuff? If I want to compensate, yes, number one, I'm going to make sure we reduce the clutter in your house, right? Make sure those pathways are open. Make sure that you're turning on the light when you need to turn on the light so that you can see where you're going. I might add some targets or cues. I might put a piece of tape in your doorway so that the cue for your brain is not thinking about the small space in the doorway, but thinking about, I have to step over that tape. That's what I was taught. I got to step over that tape. Or I might add some things, we can talk about lots of other ways to modify that environment. I might work with you on using some external cueing, and that cueing can be visual, which is looking, seeing, using your eyes, using your hearing, your auditory. That's things like music and metronome and somatosensory. There's a little bit of research working on, doing different things with, with this walking, different surfaces with your feet, but paying attention to some of that somatosensory cueing. We also can use some internal devices or strategies where we're thinking about what happens when I start to freeze? How do I cue myself? What do I do? So we'll go over those real quick. We know that visual and auditory cueing does reduce freezing. It reduces the frequency by up to 45%. So that's a lot. That's almost half. We know that visual and auditory cueing can reduce the length of a freezing episode by almost 70%. And we know that it can reduce the frequency of falls by 40%. So those are some really good statistics. So adding some of those visual and auditory cueing, they've used the cueing, auditory cueing, mostly the research has been on metronome. So that metronome helping to pace in time. There's a little bit of less research on music, but music also has that beat, and we use it a lot in therapy because it helps you. If you're listening to music you love, your brain actually spits out more dopamine in your brain. So it's a great way to enhance your dopamine. But we know that those visual cues, so having something to step over, step two, it increases your step length. So how big your step is, that's really important because those freezing happen when those steps start getting really small. The auditory cues we know help you get started. They give you that thing to get that initiation to say, oh, I got to go on the beat. Oh, I take a step. It helps with that turning. And in therapy, you should be practicing wide-based turning. There are lots of different ways to turn, but we can help you with that. But an auditory cue, just that beat of that metronome and that music is going to help. And it's going to help with obstacle management. So when you have to step over the dog toy, you have to step over a little threshold or the parking thing, out in the parking lot or up and down stairs, auditory cues have been shown to be really helpful in those ways. When I talked about internal cueing strategies, there's a couple of ways to work on that. One way is just thinking of as 5S or whatever you want to call it. It's this reset. So when you start to feel that and notice, or if someone notices that you're starting to get into those tiny little steps, so your legs are getting to that trembly, almost akinetic position, you would need to reset. So that just means stop, stand up, take a deep breath. Ideally, you need to get your feet apart. Okay. So if I put my feet close together and I get into a little flex posture, I can't pick my feet up either. I can't pick up a leg unless I unweight it, unless I take my weight off of it. So you need a wide base of support. And then you've got to just start over with that big step. So that's one way that can be really helpful, just knowing how to use that strategy. Another strategy sometimes that works is a step prediction strategy. I've also heard it called destination estimation. So when you're approaching, especially when you're approaching a doorway or an area or somewhere where you know that this is going to be a chance for me to freeze, and anytime you freeze, you have a higher risk of falling. You want to look ahead to where you're going. Two things happen. You're looking up, which is going to improve your posture, which is going to improve your balance. You're going to plan. So you're going to think about how many steps is it going to take to get to that next point, to get through that doorway, to either looking at a point on the wall or the next piece of furniture, and plan that out. That then, think back to when I talked about we've got automatic and we've got more task where you're completing a job or you're using some of those goal-directed parts of your brain. So knowing I've got to get there, and I'm really paying attention and I'm focused because I'm trying to get there in the number of steps I predicted. It makes your brain really attentional, and that can work really well as well. Some people need to spend a lot of time working on mindfulness and deep breathing and slowing themselves down, which is where those external cues like a metronome to slow you down. People that have freezing, usually they get into a pattern where they're going too fast and small, and they need to stop and slow down and go bigger and slower. So using those kinds of imagery works really well. When you can use motor imagery in Parkinson's and just picture yourself walking through that door. And that's been shown to be effective as well too. So those are some of those internal cueing strategies that you can use. And in a lot of times we'll add an assistive device. Sometimes people with Parkinson's that have freezing actually have more problems when you add an assistive device, because that becomes another task. And it's harder for their brain to sequence the cane or sequence the walking sticks. We, work with canes. I love hiking poles. Sidney will talk a little bit about hiking poles, I'm sure, show you some things. There are all different kinds of walkers out there. Sometimes walkers, make you bend over more, get your body out in front of your toes, and you end up with more freezing if you're not standing up tall and taking those good steps. So sometimes you have to add external cueing devices to help you use those devices more properly. We always try to work with, your family members, your friends, your care partners, whoever's helping you, so that, rather than them saying, come on, let's go, can't you just take a step, which is just going to make you freeze worse. They need to know too that it's like, all right, let's stop, take a deep breath. Where are you going next? Let's go, right? And then sometimes in late stage Parkinson's, we do end up modifying some of those mobility expectations. You want to think about, it's important to live your life, enjoy your life, get out and do the things you love to do. And sometimes if that freezing is so severe that all of these things don't work, then rather than stay home alone and never go out because you have your freezing, you want to find ways that you can get out safely, whether that's a scooter or whatever we end up helping you figure out. You want to continue to live a life that is as good a quality as possible. Keep moving, but keep moving safely. I think I saw a little question as I was talking, like, how do you find a Parkinson's specialized therapist or somebody that really understands Parkinson's and understands how to treat all those symptoms of your stiffness, your rigidity, your bradykinesia, your incoordination, all of those things? You need someone that understands Parkinson's. Typically a therapist, any PT or OT or speech therapist can treat you. Some have more experience than others. There are neurological clinical specialists in the physical therapy world that are certified by the APTA as to having additional training in neurological diseases. There are some training programs that are specific for PTs and OTs. I've done both. I teach for Power Moves. I teach PTs and OTs how to work with people with Parkinson's. And and giving them lots of tools in their toolbox to help you with this, helping them understand, the benefits of using these different cueing and how to do that. So those are a couple of references there for finding. They have databases where you can find therapists in your area who may have taken some additional training, because Parkinson's disease is very complex. It's a lot for you to manage, and you need a team, and you need a team that understands all of those parts of Parkinson's disease. So I encourage you to kind of look for those, or even just ask, when you're looking for a therapist, find a clinic that has therapists that's got experience with Parkinson's disease, and it's going to spend time with you during that session one-on-one to really work on some of these problems. That'd be my advice there. There's more and more of us all the time who understand Parkinson's, and once we see you for Parkinson's, we want to keep seeing you for life. We want you to come back and see us on a regular basis. We want to see you for bouts of therapy. We shouldn't be just seeing you once and saying, oh, you're good. Or we shouldn't see you when you're newly diagnosed and say, oh, you're good. I don't need to see you until you start having problems. That's the old way. When I started being a therapist, I've been a therapist 39 years now, actually. And we didn't treat Parkinson's until people were falling or so stiff they couldn't lay flat, couldn't get out of bed. And now we want to see you when you're diagnosed or even before you're diagnosed. And we want to help you along this journey and help you with these tools, which Sidney's going to talk a little bit about. Yeah, choosept.com. Yep, that's how one of the ways you can look for physical therapists and find out if they have some experience. The NexStride is one of those tools that can be super beneficial. I'm going to let Sidney talk about how that came to be and how it can help people with Parkinson's. And then we'll take a bunch of questions at the end.
All right, thank you, Maria. So actually, Maria was a huge help in kind of understanding freezing of gait when we first created this device, and helping to understand how we can create a product that can actually help people be able to walk, be able to live their lives, be able to maintain a high quality of life. So before I dive too much into the product, which is a solution for freezing of gait, I want to share with you all why I even got into this area and this topic. So I studied biomedical engineering at Cal Poly. And when I was in school, I met a local veteran named Jack Brill, who lived with Parkinson's disease, and he suffered from this mobility symptom that we've been talking about for the past 40 minutes or so, called freezing of gait. And that was pretty much the only reason that he was in a wheelchair. His legs were strong, he was able to walk around, but his freezing was so bad that his wife, Sandy, was worried about him falling, was worried that if he fell, she wouldn't be strong enough to catch him or to pick him up, and that she could get hurt as well. So he was in a wheelchair pretty much all the time when I met him. However, he knew that there were these visual and auditory cues that could be used to help him overcome freezing, because he used them in his physical therapy clinic. As Maria has been talking about, there are these visual and auditory cues that are already standard of care in any physical therapy clinic. There are over 100 peer-reviewed articles that have been published showing the efficacy of these visual and auditory cues in helping people overcome freezing of gait. But for Jack, and for a lot of people, there wasn't any way to take those cues outside of the clinic and be able to use them at home. For Jack to be able to go to the bathroom by himself, be able to go on a walk with his wife, Sandy, be able to live his life at home outside of the clinic. So here's a video of Jack freezing. So this is him trying to walk across his living room floor. You can see his legs are trembling, right? He's trying to pick up his foot, but no matter how hard he tries, he cannot take even one step. Again, you can probably imagine how incredibly frustrating that is, but it's also a leading cause of falls for people with Parkinson's disease. So what we did was take the most effective visual and auditory cues from research and combine them into a portable device that can attach onto any cane, walker, or walking pole. So we could attach this device onto the walker that Jack was already using and give him access to the auditory cue of the metronome that Maria talked about earlier, and the visual cue of a green laser line projected onto the floor in front of you. So all Jack does is he visualizes himself stepping over that green laser line or stepping to the beat of the metronome. And by doing that, by using a goal, you're activating goal-oriented neural pathways in the brain that allow you to kind of bypass the damaged neural circuits that are causing freezing of gait and be able to start walking again. So here's a video of Jack walking with our device for the first time. So you can see he's kind of stepping over that green laser line every time. Here's another video of someone who's actually experiencing a freezing episode. So he's unable to move his legs until he activates that green laser line that allows him to take those first steps. So the difference between this video and the video of Jack is that Jack will use the device continuously. So every time he's walking, he'll have the device on, and Trevor will use the device on demand. So he'll experience a freezing episode, he'll turn the device on, start walking, and then he'll turn it off and he'll keep walking just fine. So what's really special about the NexStride, which I think is important to mention, is the fact that it can attach onto any cane, walker, or walking pole. So that allows you to come into your physical therapy clinic with whatever works best for you, whether that's walking poles or a walker or a cane. Different types of walkers work for different people for different reasons, and will allow you to be able to, take these visual and auditory cues with you no matter what mobility aid you are using at that time. So I think that's really important. The other reason that that's important is that we've worked with people who will start using NexStride when they're using a walker, and then they'll go to physical therapy or start doing rock steady boxing, and they'll go to using walking poles or a cane, and then they'll go back to using a walker depending on what's happening with their exercise routine and their medication. And it's important to be able to use these visual and auditory cues consistently, no matter what mobility aid you're using at the time. We also have both visual and auditory cues, which are proven to be more effective in research than either of those cues alone. And we have on-demand cues. So that not only has an importance in efficacy, but it's also important to allow the person with Parkinson's to have complete control over when those cues are on or off. So, we already spent a lot of time looking at the research here, so I'm not going to go too much into this, but I'm happy to if there are any questions about it. But this kind of summarizes the research. We have a white paper that we also published with Dr. Becky Farley where this is pulled from, that goes into the details of the research behind visual and auditory cues. Maria talked about these numbers already of the efficacy in Parkinson's. What's interesting, I know this is a webinar for Parkinson's, but what's interesting is that we've actually seen these visual and auditory cues also be effective in stroke rehab and multiple sclerosis, and PSP, and cerebral palsy, and a number of other mobility disorders. So of people who have used the NexStride for over a month, 93% of those people have reported increased confidence while walking. 86% of people have reported increased general mobility, so being able to get up and move around a little bit easier. And 75% of people have reported a decreased fear of falling since using the NexStride. Now, these numbers are extremely important to us because exercise is the only thing that has been shown to slow the progression of Parkinson's disease. Yes, we have medications, and we have a number of other interventions that we can use to mitigate the symptoms of Parkinson's, but the only thing that has been shown to slow the progression of Parkinson's disease is exercise. So if we can give people tools to be able to keep walking, to be able to stay mobile, that's extremely important for people with Parkinson's especially. So we do have a couple of options of how you can purchase one if you think that you are a good fit for NexStride, or somebody that is a good fit for NexStride. You can purchase it on our website. You can call us. The price point is $4.99, but there are a lot of kind of options for coverage. So it is covered 100% by veterans by the VA. So if you get healthcare through the VA, you can get this device for free. Do you have any questions about that? Just call us. And then it's also 100% covered by an organization called the Parkinson's Wellness Fund. I have their website here. We will kind of send out all this information afterwards and make sure everyone has access to this. And then there's also payment plans. You can pay over time. And we have a 30-day money-back guarantee. So we want to make sure that, number one, anybody can get this, no matter what their financial situation is. Number two, we're allowing people to be able to try it. And if it doesn't work for them, just send it back to us. No questions asked. We'll pay for shipping both ways within a month. And then we did kind of get a discount code here for you all who are watching this webinar. It's PMDA 100. So Parkinson's Movement Disorder Alliance, PMDA 100. And that's all I wanted to share with you all today. I think that we have a couple questions in the chat to go over. Is that right, Kelly and Edith?
We do have a couple of questions. So I'm gonna start at the beginning. First, somebody did ask before we started if there's any suggestions for retropulsion or falling backwards.
So I'll answer that from a PT standpoint. So falling backwards, again, that's that sensory perception of where you are. It's not as typical in with freezing. Freezing, usually falling with turns, a lot of falling forward. Falling backwards is a little bit different, but getting that, getting your weight forward, having some kind of a cue or a target to keep your weight shift and your propulsion going forward. I would think that having that laser line might help keep that weight shift forward. A lot of times I'll use cues of, trying to get the hips forward, because usually that retropulsion, you're pushing with your legs and your hips aren't where they're supposed to be. They're behind your center of gravity. So when you push, you go over backwards. When you go to stand up, people call it retropulsion because you don't lean forward enough before you push with your legs, and your legs are so strong, they just push you backwards. So a lot of it is that where you are in space. So if the laser light helps you keep that weight shift moving forward, that's going to help you as well. Any kind of cue or target that's going to help get that weight shift forward, definitely something to work on with that. So that's what I would answer for retropulsion. That's a little coordination problem, I think, more sequencing, timing, and coordination with one of those Parkinson's symptoms. So
somebody asked, what causes the loss of balance in Parkinson's? If it's caused by a loss of proprioception, is this caused by peripheral neuropathy or by central neuropathy? And you might want to explain some of these terms as well.
So neuropathy would be if you have damage to your nerves and you're not actually feeling. So people who have peripheral neuropathy in their feet, they don't have good information from the ground. So they don't know where they are in space as well. We use the ground or whatever we're touching tells us we're not moving and where we are. Our eyes are part of our balance system of where we are in space, and our vestibular system. And in Parkinson's, it's more of a basal ganglia processing problem that you don't, number one, have as good a sensory perception or awareness of where you are in space. And then number two, you don't have that ability to have those automatic protective responses. So in normal balance, we get a little off, our center of gravity gets a little in front or behind or off to the side, and we sway around our ankles, but we're able to correct that. We get a little bigger perturbation, we call it. You get a little bit farther away from that, having your hips right over your feet, and you might have to take a step. And that's a protective stepping response. That's an automatic postural response that typically is impaired in Parkinson's disease, those automatic things. So that stepping response is not as automatic, and your movements, your reactions are slow because of the bradykinesia. So you don't get that foot out there. Your doctor probably tests you on the pull test, right? They'll take and pull you backwards, give you this perturbation, and then have to catch you, or they'll see if you take steps or don't take steps. And the longer you've had, that's one of the signs of Parkinson's, is that you don't get that foot out there. It doesn't catch you. So that's a problem with bradykinesia. It's a problem with probably that sensory perception of where your body is in space, more so than a peripheral neuropathy of not actually feeling the floor. It's more of a problem of your brain isn't processing now that input correctly, and your brain isn't paying attention as well. That answer that one, I hope.
And then I have somebody asked, in your experience, is there one physical therapy that seems to have more evidence-based success, like rock steady boxing, power moves, LSVT, big? So they're all based on research.
And I obviously I'm biased. I have to, claim, I should have put that bias up. I faculty for Power Moves. I teach Power Moves therapist courses. So that's the approach that I use because it is very evidence-based, and it's a symptom-based approach. So I'm going to treat all of your symptoms, whereas LSVT is more of an amplitude-based approach, right? Boxing is a lot of amplitude, right? So boxing has a lot of working on getting bigger, faster movements, but it works on your balance. It works on a whole lot of other things as well too. It doesn't have to be rock steady boxing. It can be, any kind of exercise. There's research that says yoga helps. There's research that says Tai Chi helps. There's research that says tango helps. So it's really, does the exercise or the therapy or whatever you're doing work on those components of the problems that are your specific Parkinson's problems? Do you have a lot of tremor? Do you have a lot of stiffness and rigidity? Do you have what are your problems? And so that therapy or exercise should really address those problems well. And you actually need elements of all of them.
And then somebody did ask that they asked, you used the term somatosensory, and they asked what that was exactly.
So it's your sense of where you are in space, right? So where your body is in space. So as I said, we use our sensation of whatever's touching a surface. So if we're standing up, it's just our feet, right? If we're sitting down, it's our bottom and our feet and maybe our arms. When we're laying down, we have a lot of somatosensory information. Our whole body's touching a surface. We use our vision. And you know that if you're sitting in one of those, the stop sign and the car next to you goes and you think you've moved, well, that's because we rely really heavily on our vision to help us know where we are in space. And then there's that vestibular system that also tells us, are we moving forward? Which direction are we going? How fast are we moving? And our brain then takes all that information and integrates it and comes up with this sense of, where are we in space? So somatosensory is just all the different sensory things that help us balance and know where we are in space.
Now I got a few, don't go away though, Maria, not that you're going to, because I got a few for Sidney, but then I'm coming back to you again. Sidney, I have a bunch on kind of, so I'm going to ask them all, but somebody asked, what is your opinion on Ustep? Because in the slide, why we started, there is a Ustep walker in front of Jack. How does NexStride compare to the laser cueing model that Ustep offers? How do they differ? And then somebody also asked if this was covered by Medicare or available in Canada. And then I have more questions, but I'm going to just give you a bunch.
Yeah, great question. So the Ustep, and Maria can kind of jump in here because she has experience using the Ustep with her patients as well. But from the information that I have from talking to all the physical therapists and talking to all the people with Parkinson's that we work with, the Ustep is a great walker for some people in some circumstances, but it's not going to work for everybody. For example, Jack would use the Ustep sometimes when he was walking around his house, but anytime he left his house, he couldn't use the Ustep because his wife couldn't lift it in and out of the car because it weighs 32 pounds. So it weighs 32 pounds with the cueing. It costs over $800. And so that makes it inaccessible to a lot of people. So it's different about our device versus the Ustep is that our device can actually attach onto any cane, walker, or walking pole. So some people actually do attach it onto the Ustep and use it with the Ustep. Some people have the Ustep and they have the NexStride attached onto a cane or a different walker for when they leave the house. So it just offers something different. It offers both the visual and auditory cues onto any cane, walker, or walking pole that works best for that person. So that's the difference between the NexStride and the Ustep. Go ahead, Maria.
So the Ustep is a walker specifically designed for Parkinson's, and then you can add a cueing module that has visual and auditory cues. It has a red laser light, and it's kind of a fixed thing. The walker is shaped like a U. It is bigger and heavier, and for some people, they need that stability. And so it does work well for some people. It also has a reverse braking mechanism where in order to go, you have to be intentional and squeeze the brakes. in order to go. And when you don't squeeze the brakes, it stops. So it does make you more intentional with your walking. But again, not everybody who has freezing of gait actually needs a walker, right? A lot of people with freezing of gait don't need that kind of a big, heavy device. So having something that's portable is part of the big benefit of having something that can go on to different devices and can be used easily and accessible. So it's also very much that on demand. Like if you want to turn that on, you can turn it on. You can use that light. You can, I as a therapist, I don't always want people looking down because that might make their freezing a little worse. But if they can project that light out farther out in front of them, that may help cue them to take that nice big stride. Maybe they just need to turn it on and do it a time or two and then think, okay, now I'm going to imagine, I'm going to use motor imagery and I'm going to use that device, or I'm just going to turn it on when I get in a crowded situation or when I need it, because I'm starting to feel that trembly in my legs. So that flexibility, that ability to turn it on and off, to use it in different ways, to use the auditory or to use the vision, depending on the situation, is really, really beneficial. But the Ustep, can come with those same kinds of cueing devices, but it's just a fixed device on that. They do have a laser cane as well. I've seen, I had somebody once had little lasers that were to go over the tips of his shoes, and he's like, there are lots of different kinds of devices out there, kind of because as Sidney said, the research on the efficacy or how well cueing works with freezing has been out there for quite a while. So it's just trying to, think about all those different options and what works for you. As a therapist, I want to work with you. I want to figure out what works with you, practice with you, help you come up with the best strategies. And it's maybe different depending on where you're walking and what you're doing, right? So as much flexibility as possible is important.
Yeah, and I want to jump in there and address, I saw the comment from Nick that looking down at the floor, having a laser that's at your feet forces you to look down at the floor. That is true. Some people, like in the video, we do show it right above the person's toes. But the great thing about the NexStride is that we actually designed it so that you can move the laser out in front of you. You can have it 3 or 4 feet in front of you so that you can keep your posture up and be able to look at the laser in front of you. And we can see here, you can just kind of move the laser back and forth this way. And then I know that there's a couple other questions. Is it covered by Medicare? Not yet, but it is covered by the VA and the Parkinson's Wellness Fund. Is it available in Canada? Again, unfortunately, not yet, but if you call us or email us, who is that, Sue? If you call us or email us, we can figure out a way to get you a sample even before we launch in Canada.
What about the battery? Somebody asked about if there's a battery for it, how long does it last?
Rechargeable battery, and it lasts for 6 to 8 hours with the device on, with the laser on the whole time. So usually for our patients on average, that means that they're going to be charging it about once a week is what we've heard.
And someone asked how they can get the white paper you published.
So we can send that to you all, or we can put it in the slides that you guys are sending out, but it's also on our website. We also have an ebook, more information about freezing and Parkinson's available on our website.
Couple real quick, how much is freezing of gait due to off time?
I don't know the percentage on that, but again, when you're off, your medications aren't working, you're needing to take your medications, you're going to be stiffer, you're going to be slower, you're going to have more problems with initiation. So you're usually freezing is more of an off, can be, some people it is, some people have it no matter whether they're on or off, but a lot of people it is related to that off time when they just can't get moving. I do not know the percentage on that. I'd have to look what the research shows. Again, I don't know, it's different for everybody, but a lot of freezing is related to off time, but some people just freeze all the time, no matter where they're at.
That's what's so interesting about the research. There's off-related freezing, there's on-related freezing, and then there's independent freezing, where somebody will freeze whether they're on or off. It's very interesting.
And that's because you all have a disease that is so completely complex and different for everybody. It's really hard. The research is hard because everybody's so different.
And just a couple more questions, if you can give us somebody did ask if the boxing is damaging to the hands or arms.
Boxing?
Then, yeah, she was just asked about the rock steady boxing.
Well, it depends. So boxing doesn't have to be a lot of, boxing incorporates a whole lot of things, and it can be, you don't have to be hitting heavy bags all the time. And I've seen some boxing instructors who do a lot of hitting, and then that can be problems with upper extremity stuff, but you can do a lot of those movements just with, it doesn't have to be hitting anything. You do shadow boxing, there's footwork and there's weight shift and there's amplitude. There's a lot of good things that go along with it, but it doesn't have to be hitting heavy bags all the time. There doesn't have to be that component. But I have had patients who do end up complaining that they just can't do that, hitting those bags. And it's not necessarily appropriate for everyone, but you can incorporate boxing moves into any kind of therapy without needing any equipment at all.
And then, because you had mentioned the hiking poles, somebody asked if there's a brand you recommend or if there's any you recommend. So
if you're looking for information or education about how to use hiking poles, there is a company called Urban Poling, and they have worked with Sidney and done some stuff with the NexStride on their poles. It's an occupational therapist from Canada who developed these poles that they have a different handle that has a ledge, so you really can use that. People with Parkinson's do well when they have, they get in a good tall posture, and the handles on that pole help. They also can come with bell tips instead of just the Nordic walking tips, so they can be used in different ways. There's another company called NexStride that has a similar pole, but Urban Poling has a lot of education on their website about pole walking, pole exercise, all kinds of different things there. But I even use PVC poles in therapy because they're easy and I don't have to switch them. So it's that idea of, what works best for you. A good quality pole, the bigger the tip, I think you get a little more feedback through them and it's a little bit easier, but I'd recommend Urban Poling just because they have so many educational offerings for you.
And then last question, how much of freezing of gait is fatigue related?
So it depends on, and that, I don't know, Sidney was talking about the different, medication related or just independent freezing. If as you get more fatigued, your posture worsens, your base of support gets narrower, you're getting out over your feet, you're just going to tend to have more freezing from a functional standpoint because you can't pick that foot up and get going, right? You're too tired to get up into a nice tall posture, and that is going to increase your freezing. People with Parkinson's tend to just, those eyes are focused down on the floor. You're looking right in front of you. And that, again, as we talked about, sometimes having that laser light out ahead is much more beneficial than having it right underneath your feet. So the tireder you are, the more fatigued you are, that is going to contribute to a bigger risk or chance of freezing, I would say. I just don't know the statistics on that. Those are good questions to look up.
We are past time, so I do just want to thank both Maria and Sidney for chatting with us today. As always, we have a tradition at PMD Alliance, our wave of gratitude, and we just want to say thank you so much. This was so wonderful and educational, and we're so grateful you guys could hang out with us today and share your knowledge.
Thank you.
Thank you. Yeah, thank you so much for having us. This was really fun. Great to meet all of you guys that joined.
And they are sharing their slides and everything. So if people want to go over their slides, that will be available. It'll be sent out to you. So thank you. Thanks everyone for joining us.